Okay, let's dive straight into obstructive lung disease for Step 2 CK. We're skipping the fluff and focusing strictly on the clinical decision pathway and the exact next best step logic you need for the boards. We're going to move quickly through the obstructive wheeze differential, asthma versus COPD, diagnosing suspected asthma, managing stable COPD, acute COPD exacerbations, and finally, severe asthma. Starting right off with Section 1, the obstructive wheeze differential. When a patient comes in wheezing, your first job is separating mimics from true obstructive disease. Take acute bronchitis. You treat this symptomatically, right? No antibiotics. That classic purulent sputum you might see, it's actually just epithelial sloughing, not a bacterial infection. Bronchitis typically follows a viral URI, causing a cough for 5 days to 3 weeks, but crucially, it completely lacks systemic pneumonia findings like fever and chills. Oh, and keep vocal cord dysfunction and pulmonary embolism in the back of your mind for acute wheezing without an infectious trigger. Here's a massive differentiator for the exam. If the arterial blood gas shows a low CO2 and respiratory alkalosis, think congestive heart failure. Pulmonary edema basically cuts down ventilation and drives up tachypnea, so the patient blows off CO2. On the flip side, a COPD exacerbation presents with respiratory acidosis, high CO2, and widespread wheezing. Watch out for the anaphylaxis trap. It can perfectly mimic an asthma exacerbation if skin involvement, like urticaria, is minimal, or if the clinician just misses it. You really want to suspect this if the vignette casually mentions recent NSAID use. NSAIDs activate mast cells and severely worsen the reaction, leading to rapid laryngeal edema. Moving on to Section 2, asthma versus COPD. Both of these core obstructive diseases feature an FEV1 to FVC ratio below 70%, and that produces this really classic scooped-out expiratory phase in the flow volume loop. But honestly, we need a bit more data to actually tell them apart definitively. And this right here is your golden key, the DLCO. Asthma retains a normal or even high diffusion capacity because the alveolar capillary beds are perfectly intact. But in COPD, emphysema literally destroys those capillary beds, dropping the DLCO. Plus, asthma features reversible obstruction. We're talking an FEV1 bump of at least 12% after bronchodilators, whereas COPD is non-reversible or, at best, only partially reversible. Keep this red flag warning in mind. Hyperinflation, counting 8 or more ribs on an X-ray, a flattened diaphragm, those are all completely expected in COPD. Digital clubbing is absolutely not. If you see clubbing in a COPD vignette, you need to look for an alternate diagnosis, like occult lung cancer, bronchiectases, an abscess, or empyema. Section 3, diagnosing suspected asthma. Let's see how this builds on our spirometry foundation. If a patient has intermittent symptoms, like cough, dyspnea, or chest tightness, start with spirometry. If the baseline shows obstruction, you confirm asthma with bronchodilator reversibility. But if the baseline spirometry is totally normal and your clinical suspicion remains high, your next best step is methacholine bronchoprovocation testing. If that comes back negative, asthma is off the table, and you need to find an alternate diagnosis. Remember that comorbid GERD can seriously worsen asthma, and it does this through increased vagal tone, heightened bronchial reactivity, and microaspiration of gastric contents into the upper airway. You'll usually see this as a worsening cough specifically at night, or a patient needing their albuterol inhaler right after meals. The right move here? An empiric trial of proton pump inhibitors. For occupational asthma, establishing that workplace relationship is a very precise sequence. First, you confirm the asthma diagnosis with spirometry. Then, you rely on serial peak expiratory flow measurements that the patient records at home and at work. You're looking for a 20% or greater decline in those flow rates at the workplace compared to when they're at home. All right, Section 4, managing stable COPD. Long-acting muscarinic antagonists, LAMAs, and long-acting beta agonists are your absolute mainstays here. Now, inhaled corticosteroids are treated very differently in COPD than in asthma. They're only added for Group E patients who have frequent exacerbations and a high peripheral eosinophil count above 300, and definitely avoid them if recurrent pneumonia is a risk. Oh, and smoking cessation, that's a true game changer for survival. Options are varenicline, nicotine replacement, or bupropion. Just remember to skip bupropion if the patient has a history of seizures or an eating disorder. Burn these numbers into your memory. Providing home oxygen is one of the only interventions actually proven to improve survival in COPD. The standard indication is a resting PaO2 of 55 or less, or an O2 sat of 88% or less on room air. But if the patient has cor pulmonale, right heart failure, or a hematocrit above 55, that threshold bumps up just a bit to a PaO2 of 59 or a sat of 89%. Moving to Section 5, acute COPD exacerbations. When stable COPD decompensates, you need to maximize expiratory flow with inhaled bronchodilators and hit airway inflammation with systemic glucocorticoids. Then you're assessing for the 3 cardinal symptoms: increased dyspnea, increased sputum volume, and increased sputum purulence. The exact combination of these dictates your next steps. This is absolutely crucial. Strictly target an oxygen saturation of 88 to 92%. If you push the oxygen higher, you can blunt their hypoxic drive and cause worsening hypercapnia. That leads straight to dangerous CO2 retention, which we definitely want to avoid. Don't just throw antibiotics at everyone. They are indicated only if increased sputum purulence is present alongside at least one other cardinal symptom, or if the patient requires mechanical ventilation. Now, if they go into respiratory failure, non-invasive positive pressure ventilation, or NIPV, is your go-to. But if NIPV fails, or if you see severe acidosis, altered mental status, or hemodynamic instability, that's when you step up to intubation. Finally, Section 6, severe asthma and its complications. Normally, a patient having an acute asthma attack is hyperventilating, so their PaCO2 should be low. If you look at the blood gas and see a normal or high PaCO2, that means their respiratory muscles are tiring out. Impending respiratory failure is right at the door, often along with a silent chest or altered mental status. Treat these severe exacerbations aggressively with nebulized albuterol plus ipratropium and systemic glucocorticoids. If they don't respond well, add IV magnesium. And quick note for asthma and pregnancy, the treatment is mostly the same, but target oxygen above 95% and avoid epinephrine. To wrap up this explainer, remember that Step 2 CK focuses heavily on your immediate decision logic. You have to nail the diagnosis via spirometry, optimize stable disease to prevent exacerbations, and recognize the strict numerical thresholds for oxygen, NIPVP, and intubation. Master these specific next best steps, and you'll crush these questions on the exam.